Dr. Taha, comment to your question. I think now the blood bank, international recommendation of the blood bank, and if you need to get the accreditation, you have to screen all the blood donors using the PCR. And this is it's mostly applied in most of the centers in the country by now.
It is the recommendation. Everybody should have PCR.
So serology is out for screening, and it will come in the future that there should be no serology for screening. It has to be the PCR.
For the blood transfusion?
Yeah, for donation.
Well, that's what I said. That's the NAT. It's called the NAT, or nucleic acid testing. Now, they do it in a special way, because if you do a PCR for every donor, you will run out of money. Even in Saudi Arabia, mashallah, mizaniya kanat mubarakah, you will run out of money. With every donor, you do a PCR. So the NAT of nucleic acid testing is that you will take 100 donors and you will pull their blood and you will do the PCR on the 100. If you get negative, the next 100. So you save a lot of money. If it's positive, then you have to go back to the 100 and then divide them into 50 and so on. So the NAT is now the only way that you have to screen out infected patients.
Right. So even if you are hepatitis B surface antigen negative, it is not safe to take blood unless you have at least the anti-hepatitis B core IgG negative. Any question?
May I
Fadal Khalid.
ask Dr. Taha, now the patients being seen in family practice, who's the patient or the inactive carrier patient, hepatitis B inactive carrier? Are they potential to be followed in primary health care by family medicine consultant or not?
I think that's an important question. And what we outlined here would hopefully help us in making a decision about that. It sounds simple. Look at the DNA, look at the ALT, and look at the quantitative hepatitis B surface antigen, and you can at least determine who not to treat. You may or may not need a liver biopsy.
You made it complicated by looking for a surface antigen.
Yes, but I think the surface antigen...
Do you have the test, Taha?
Yes.
Do you have it?
Yeah, it's surface antigen, I am certain will be in the next guidelines. It's a simple test. You can either use what's called Architect, that's Abbott, or you can use what's called Alexis, which is by Roche. It's a simpler test than the DNA. It's much cheaper than the DNA. So if you just tune yourself to doing hepatitis B surface antigen, quantitative level, in every patient who comes for the first time to your clinic, it will help you enormously. So if you have less than 1,000, DNA less than 2,000, ALT normal, we don't want to say what do you mean by normal, but let's say normal, then I think you are a safe ground to say that this is an inactive carrier who will not need treatment, but you should follow the patient up closely for the first year. Now, if you want my advice, what I would say is that the decision should be a joint one between the hepatologist and the primary care. So what I would suggest is that every patient newly diagnosed with hepatitis B should first be sent to the hepatologist. Then he will do what is necessary. Once he makes sure that the patient is an inactive carrier, you can have your patient back, but you now are aware exactly why the decision was made to diagnose him as inactive carrier, and what is it your job to do, which is to, for the first year, every 3 months, make sure that the DNA stays low and the surface antigen stays low and the ALT stays low. So I would say that first of all, the hepatology opinion, and then I think the patient should be handed back to his primary care physician.
Introduce yourself, please. Dr.
Family medicine resident. My question is for Dr.Hind. Regarding fatty liver, when it's proved by ultrasound that my patient has fatty liver, fatty changes in the liver, when to refer to gastroenterology, and the fibroscan scan. Is it available? Do we have it here? And how often do I need to follow the patient?
As long as your patient is maintaining normal ALT and AST, probably you don't need to worry. He's not yet even NASH, right? So just fat deposition in the liver, what we call the first stage, which is NAFL, non-alcoholic fatty liver, right? Fibroscan is available. We have it. I think probably other, I'm not sure. King Faisal برضه they have it. I'm sure like soon you'll have it everyone, every center. If you're worried, you could refer the patient for Fibroscan 1. Check his fibrosis
So, no,
score.
she found it on ultrasound, right? You find it on ultrasound, but with normal liver enzymes.
Ultrasound. You expect this patient to be stage 0 or even stage 1 and follow him. It's the alarming problem when you have abnormal liver enzyme. There you refer the patient to the hepatologist and we can go from there.
So, Hind, what do you consider the liver enzymes normal? Is it the same we're speaking in hepatitis C? Is it 30 and 19, or you go for your lab?
If we discuss the liver enzymes, we'll stay until tomorrow.
Hmm?
We're going to stay until tomorrow if we're going to start the normal liver enzymes. Normal liver enzymes, your normal liver enzyme is not like, your normal ALT is different from my normal ALT.
Right.
Because ALT is related to age, sex, and BMI. Female, they have lower ALT. Male, they have higher ALT. BMI, the bigger the BMI, have higher BMI. So everybody has, like, we have to standardize the liver enzymes, and you cannot do that. Actually, the laboratory standard, they call it Federal Laboratory Association. In the state, they're trying to standardize it like the INR. Because we did one study, and I looked around all the studies, even the parity studies, the first study, which was in 2002. What we are looking at our laboratory is not true normal. It's not true normal.
Do you add anything, Taha? As for fatty liver, do you consider 30 and 19, or you go for the body mass index?
على فكرة 30 and 19 هذا بالmethod that was used by party. You have a different method in your hospital. I have a different method in my hospital. He has a different method in his hospital. So 19 in party study is like 26 in my method.
Right.
So I cannot go with the 19.
Okay.
So the 30 and 19 came from Italy. Yes, by, as Dr. Hind said, someone called Prati. And as you know, the Italians drink a lot of wine, khamr. So you would expect, and they are also obese, so you would expect their transaminases to be elevated for the reasons that Dr. Hind mentioned, which is the obesity and wine. But in spite of that, when he excluded, it was a meticulously done study in which he excluded any patient who had any confounding factor. He came to the conclusion that men were 30, the upper limit, and female is the 19. Now the funny thing is that result was duplicated almost exactly halfway across the world in Korea, or was it Taiwan? Korea, a man called Kim. And he showed exactly the same thing, that the upper limit of normal ALT for men is 19. He took 40,000 patients who were in insurance and so on and so forth. So to me, Saudi population does not drink. Yes, we are obese, but we don't drink. على الأقل معظمنا. So I would expect that the 19 for females and the 30 for males is reasonable. So that's what I take nowadays.
طيب, Abdul Jabbar, I think still in primary health care, the same as Dr. Abdurrahman Jibreen mentioned in his first lecture, is still reflux disease, is still there is place for antacid, as you said, as you mentioned, yani once a week, once a month reflux. You don't need to jump for the big guns. Yani sometimes what we face in real life, that patient comes to us with taking maximum dose of esomeprazole, 40 BID, for example. So always give a chance for lifestyle modification, and this is stressed upon by Dr. Abdurrahman. And again, your point is valid. You have to step up anti-acid, H2 receptor antagonist, and then you go for PPI. Everybody agree?
No.
No?
Yes.
He want to hit hard.
No. I think, Hamad.
If you have once heartburn, once a month.
Yes. I'm old enough to remember when there was no PPI and no H2, you're all very young, and no H2 blocker. And the life, and we used to use antacids, aluminum hydroxide, which causes constipation, magnesium sulfate, which causes diarrhea. They're terrible. They honestly are. You have to have a liquid with you all the time. Occasionally tablets. Side effects are there, as I mentioned. You have constipation, you have diarrhea. You remember, you never saw it, the milk alkali syndrome. Hamad may remember that in the old MRCP days. And I think that the PPIs were a mu'jiza, simply a mu'jiza. And to have a patient, instead of taking a bottle, keeping a bottle of a liquid or many tablets, taking it 3-4 times a day, you can use one tablet once a day. You don't need to use 40 milligrams. Lansoprazole, rabiprazole, they go down to 10 milligrams. So what I do in my practice is I give them a full dose. I rarely ever use BID, 40 milligrams. I give them a full dose. Once they are responsive and they are confident, then I ask them to step down. And the step down will be to the lowest dose and maybe 2 or 3 times a week and so on.
المشكلة في الحرس الفاميلي ميديسن you are allowed to write the Nexium, esomeprazole. طيب, okay, so any other comment? تفضل يا دكتور.
Dr. Ahmad, family physician. Actually, for Dr. Taha, my question, he said about the strep test for hepatitis C virus. I think if we can apply this program for the primary care, I think this will be much budget or huge budget need to be supplied from
C ولا B قصدك؟
Dr. قال B. C.
B. دكتور طه. B.
Even for the hepatitis B virus,
Okay.
that means we'll have the screening program, need a budget, and each patient with high risk or normal risk will do for him screening program.
Well, you see, C, my basic rule for C is treat unless there is a contraindication. We don't have the difficulties, even patients with persistent and normal ALT, I treat them, especially if they're young. So my approach to C is completely different from B, and it is treat unless there is a contraindication, unless the patient has a problem. Because in the final analysis, it is, well, we can go into the reasons when we talk about the normal ones, but even with the normal ones I treat, the normal ALTs usually are 25% of patients will have normal ALT. These are usually young people. They are thin, like Dr.Hind. They are young, they are female, and these are the patients who respond. If I wait 10 years until the patient becomes obese, more fibrosis, age is older, as Yasser told us, less than 40 is better, I think it's a problem. I treat them also for social reasons. Young people will want to get married. If they have got hepatitis C, there will be a problem with their marriage. People want to get employed. They will never get employment. And at the end of the day, it is an infection. So I think, particularly in this day when we have the triple therapy, I would treat everyone unless there was a contraindication. But B, this is what we need to do. And I will just add one thing, Hamad,
Yes.
if you will allow me.
تفضل.
The Italians are beginning to relax the severe criteria for the hepatitis B. Because what they say is that we have effective drugs which are very effective, no resistance, and very safe. So we should treat more and more people. In the old days we had interferon and we had to do this selection and so on and so forth. But that's a special...
Dr. Taha, that means we have this curative rate, we said around 52%. Is it all this risk factor? I will face each patient with hepatitis C. I will treat and all complication he may face it, or that I will give choose to the patient either to treat it or not?
For hepatitis C?
Yes.
Treat.
Sorry, so I didn't get the...
No, you treat. You don't, the success rate is up to 60%. Don't wait.
He said
As he said, all patients like Hind, thin, young, low ALT, you should treat. Even if the liver enzymes are normal,
I think so. And you see now with the new drugs, with the new protease inhibitors, you are talking about 75% SVR.
دكتورة؟
Yeah.
وراك الدكتور وراك. عرف على نفسك لو سمحت. طبعا again for hepatitis C, HCV antibody alone is not enough. As Yasser said, it takes maybe up to 16 weeks for the antibodies to become positive. So you need the PCR for donation. At least it will reduce it to 1 week up to 2 weeks. Okay, Doctor?
Dr. Tawfiq Shihab, family physician. My question for Dr. Hind Fallatah, for a patient who is diagnosed to have a fatty liver disease, how often should I repeat the liver function test? Just to make sure that he's not changed from normal to abnormal.
I think the first moment I will see abnormal liver enzymes in a patient who has fatty liver disease, I will review the patient medication, as mentioned by Dr. Yasser and Dr. Taha before. Probably I would just hold, first I would just hold every possible medication that can cause liver injury or liver harm. I'll go for the fibroscan, I'll go from there. If it's drug-induced, probably I just go to the routine follow-up. Usually it's around 3 months or 12 weeks, it's reasonable time for follow-up. But if the patient, like fatty liver disease is not a disease that causes acute liver damage or sort of acute hepatitis that I need to follow the patient closely. No, sort of chronic disease, long-standing disease, like atherosclerotic complications of diabetes after 20 or 15 years.
Okay, Dr. Hind, just one more. I'll give you the closest example of a patient I known to have a fatty liver. That's me. I was diagnosed in 2007 when I was just an intern. But I never did any liver testing. I would never had any history of medication, nor alhamdulillah, I'm not an alcoholic. Should I be worried?
In my opinion, at this age, yes. Just check your LFT, check your fibroscan, and you go from there.
By the end of the day, you made me scared. Thank you.
Doctor, last question. عرفي على نفسك.
دكتورة Dr. Manaf Rashid, consultant family physician. There is a common scenario we face in diabetic patients. They have high liver enzymes, up to 2-3 folds normal, with isolated increase in triglyceride. Should we refer the patient for ultrasound for the liver, or we can empirically treat the isolated increased triglyceride with fibrates and statins? This is a very common, I see in my clinic.
This is a very good question because, most of the fatty liver disease is actually due to deposition of triglyceride in the liver. It's not the deposition of cholesterol. I would treat the hypertriglyceridemia and I follow the patient liver enzymes. I may add polyglucophage. I know it's not so effective, but it's what's available in the market. Or glycosone group to control the patient diabetes. The patient is so obese. Probably I will think of bariatric surgery.
Thank you.
Thin patients, not
Thank you, Dr. Hind. I'll give this to Dr. Khalid to close the session.
Before we close.